Good day. I would like to thank Cecilio and the Brazilian Society of Extracorporeal Circulation for the invitation to speak today. I had the good fortune of meeting several physicians and perfusionists from Brazil while I was traveling there and when they have visited me here in Boston. I truly appreciate those relationships as we all aim to help the children which come under our care. Today we will look at the use of the hemoconcentrator, and I have titled my talk, The Hemoconcentrator, Unsung Hero of Pediatric Cardiac Surgery. I chose that title because I truly believe that the hemoconcentrator can be a powerful workhorse for the perfusionist and surgeon in the operating room when used to its fullest potential. So for discussion today, in the time we have, we will discuss what a hemoconcentrator is, when we use it, why we use it, and very importantly, how exactly we can use it. That is a very important question we will cover. It is my belief that ultrafiltration practices must be considered collectively to maximize the potential benefits to your patients. So for starters, what is a hemoconcentrator? Or what is an ultrafilter? The term hemoconcentration truly means to take volume off and replace it with another solution, while ultrafiltration truly means to simply remove volume, as with conventional ultrafiltration. We will use those words interchangeably today, as most people do. I chose to display the technical specs for just two small hemoconcentrators, as they are very commonly used. My practice utilizes the Mintec HBH400 for neonates and infants, while I know that several centers in South America utilize the Sorin DHF02. Both are quite comparable, and I do not see a realistic clinical advantage between the two. I will note that typically I limit overall flow through the device to 350 milliliters per minute based on the experience that flow rates of 400 or 500 mLs per minute or near a device's maximum increase the risk of disconnects with the high pressures generated. I won't spend time on how an ultrafilter works because I believe everyone here today understands that very well. Though a key concept is that hemoconcentrators remove electrolytes and small particles, including mediators of inflammation, lactate, and other evil humors, as we like to say here in the United States. This knowledge has driven the use of hemoconcentrators in pediatric cardiac surgery from occasional use to universal use. And that universal use is because the hemoconcentrator can be used during all of the distinct phases of cardiopulmonary bypass. Before bypass with pre-bypass ultrafiltration, while on bypass with conventional ultrafiltration, and of course, after bypass with modified ultrafiltration. We do not have time to discuss a literature review of pre-bypass, conventional, and modified ultrafiltration, but I also do not think it's necessary. Intuitively, it makes sense to optimize the pump blood whenever possible and to return as much patient whole blood to the patient as possible after a surgical case. And that speaks to why we are using ultrafiltration during the distinct phases of bypass. In the pre-bypass period, pre-bypass ultrafiltration, or PBUF, is a very simple and effective tool to make blood primes more physiologic. There is typically ample time before the pump run to perform this, and at Boston Children's we have devised a system which allows for flexibility in case there is no time, as with an emergency. We commit to the PBUF procedure only if time permits, and frankly I'd estimate that at about 99% of the time. Moving on to the bypass period, conventional ultrafiltration, once again, is the practice of simply removing excess volume, whether it be from patient volume overload or fluid returned to the pump reservoir from valve test solution or cardioplegia delivery. But importantly, one should also use ultrafiltration during the case for zero balance ultrafiltration if blood products are added. This simply involves adding balanced electrolyte solution in an amount similar to the blood volume added and then removing that volume. Just as was the case with pre-bypass ultrafiltration, this will improve electrolyte disturbances caused by bank blood. I would add that in my practice, I aim to add any required blood to the pump before cross-clamp removal so that zero balance ultrafiltration can be completed before cross-clamp removal. This allows the heart to see more physiologic blood with improved electrolytes during initial reperfusion. Finally, ultrafiltration can be performed after bypass with modified ultrafiltration, or MUF. I have a keen interest in MUF as no one can argue that it intuitively makes sense to return as much patient whole blood as possible after the pump run. But as you will see in the upcoming slides, just how exactly you perform MUF is exceptionally important as well. Now, most often when I discuss hemoconcentration with other centers, I discover that they use passive ultrafiltration during the case, and also before if they employ PBUF. This diagram shows a typical setup. Note that the source of blood for the hemoconcentrator is post-oxygenator. The hemoconcentrator flow is passive and is determined in part by the overall system pressure. If you are doing a neonatal case or utilizing low flow bypass, your hemoconcentrator flow and the ability to remove volume will be limited because system pressure will be low. Also, note that flow through the hemoconcentrator in this arrangement is such that flow enters the bottom of the device and exits the top. Air is continuously purged to the reservoir. Additionally, this type of setup allows one to switch to active ultrafiltration, providing ultrafilter blood flow with a pump head after bypass if they perform MUF. Some people use the cardiplegia head for this purpose. There are numerous options. This is not how we do things in my practice. Therefore, it is important to describe exactly how we set up our hemoconcentrator system. It is my belief that perfusionists should standardize to active ultrafiltration for the entire bypass run for a few simple reasons. And this active ultrafiltration must source blood from the venous limb of the circuit. That is exceptionally important to prevent the possibility of entraining air into the blood across the hollow fiber membrane oxygenator. So let's look at the setup that I believe is exceptionally safe and effective. This diagram shows an exclusively active ultrafiltration setup for all types of ultrafiltration. Here, there is a pump head which always sources blood from the venous line. It pumps blood to the top of the hemoconcentrator, and that blood then exits the bottom and can go back to either the reservoir or to the pump boot line. The return is to the reservoir for pre-bypass ultrafiltration and active ultrafiltration during bypass. It is to the pump boot line during our method of MUF, or modified ultrafiltration. This setup for MUF is a variation of the technique described by the Halifax, Nova Scotia group back in the year 2000. To note, with this arrangement, there is no possibility of pulling air across the hollow fiber membrane oxygenator. Any negative pressure would be exerted on the venous line. It would therefore pull from the venous flow or from the reservoir through the venous connection. Using this arrangement allows one to utilize a single, consistent method of active ultrafiltration throughout the case without relying on system pressure or worrying about the difficult to quantify shunt, as with passive ultrafiltration. And during MUF, I believe it is safer. There is no cerebral steal, which is particularly noteworthy if you do not have access to near-infrared spectroscopy. There is also no coronary steal after bypass. Ultimately, with this MUF method, there is no afterload reduction, but there is a preload reduction, so that must be considered. But first, let's look at the phases of the operation in which ultrafiltration is used in more detail. The first phase to discuss is pre-bypass ultrafiltration, or PBUF. There is no industry standard for this technique, but all methods have the same goal of improving blood primes such that they are more physiologic. As mentioned earlier, we use a method which has the perfusionist perform a standard blood prime, and then PBUF can be performed afterwards. In a neonate or infant circuit with a prime of 215 to 275 milliliters, after standard blood priming, we add 100 mLs of plasmolyte and 80 mLs of half-normal saline to the circuit. This volume is hemoconcentrated off, and then 5 milliequivalents of bicarb, 300 units of heparin, and 100 milligrams of calcium gluconate are added to the circuit to account for losses during pre-bypass ultrafiltration. This method has resulted in exceptionally consistent primes for our small patients. This table shows our initial experience with 300 neonates in infants. You will see that many of these values improved towards normal with PBUF. But also important to note is the fact that the variation from case to case was much less. We no longer have potassium levels which are exceptionally high, just as an example. Certainly, PBUF makes blood primes more physiologic, and we plan to adjust our technique further towards normal after we study outcomes with the technique we have currently in use. Here is a quick video depicting PBUF. In the interest of time, this video will be played in fast forward mode at 4 times normal speed, since much of what occurs during pre-bypass ultrafiltration is simply adding volume and hemoconcentrating it off. So here's the video. The perfusionist has completed the blood prime and is ready for pre-bypass ultrafiltration. The reservoir level starts at 75 milliliters and 100 milliliters of plasmolyte are added. Then 80 milliliters of half-normal saline is added. The ultrafiltration head is turned on and the ultrafiltrate line is removed. The volume is taken back down to 75 milliliters. As a reminder, the flow path is from the venous line to the ultrafiltrate head to the ultrafilter top, out the bottom, to a stopcock that connects to a line which returns to the reservoir. Once the volume is down, 5 milliliters of bicarb is added, followed by 300 units of heparin and 100 milligrams of calcium gluconate. The ultrafiltration head is eventually turned off and a prime blood gas is sent. And here are the specific results after PBUF on this case. Note that several values like the pH, PCO2, PO2, and calcium are unchanged, but that there were positive improvements in the sodium, potassium, glucose, lactate, and osmolarity. I cannot stress enough that this is exceptionally simple to perform. Transitioning to ultrafiltration during bypass, this quick video shows active conventional ultrafiltration with the same blood flow path as that which was used for PBUF. Active ultrafiltration can be performed at any time during bypass. The flow path is the same as that which was used during pre-bypass ultrafiltration, running from the venous line to the ultrafilter head, to the top of the hemoconcentrator, to the bottom, and then back to the venous reservoir. The ultrafiltration head is simply turned on as needed. The process is simple and effective and does not needlessly add a shunt to the arterial limb of the circuit. It is also not dependent on system pressure. Finally, we come to MUF, or modified ultrafiltration, which is performed after separating from traditional cardiopulmonary bypass. The one change to the active ultrafiltration circuit is that the stopcock on the boot line is turned to direct hemoconcentrator flow to the oxygenator. This allows the blood during MUF to be oxygenated, ventilated, heat exchanged, and of course, filtered through the arterial line filter, whether that is with an external or integrated arterial line filter. We tend to flow 10 to 30 mLs per kilo per minute during MUF, paying close attention to the preload reduction. If the patient is a neonate, the pulse pressure will decrease too much if MUF flow is too high. Vacuum may be applied to the ultrafilter if you would like, but very often I do not add vacuum. Vacuum increases the rate of volume removal, and it can be difficult to maintain a steady volume status in very small patients. And here is a diagram of our method of MUF, which is a veno-arterial form of MUF. Some important benefits of this form include the fact that the hematocrit sensor is integral to the MUF circuit if using a inline blood gas monitor, so you can monitor your hematocrit in real time during MUF. There is also no risk of drawing air across the oxygenator membrane, as discussed previously. There is no risk of cerebral steal or coronary steal. There is no need for a separate heat exchanger, and there is no changing the cardioplegia system to accommodate MUF at the end of the case. And very importantly, the arterial line filter remains integral to the MUF circuit. Now let's look at MUF on a patient. This is a real patient case. I would like to show you this 10-minute MUF period in just 2 minutes. In the interest of time, once again, this video will run at 4 times normal speed. But first, let me orient you to our setup. The patient's head would be up here. This is the attending surgeon with their headlight. This is the venous line coming down to the reservoir. This is the arterial pump. The pump boot line goes into the oxygenator, and this is the arterial limb heading up to the patient. The MUF head is hidden back here. This is the ultrafilter, and once again, venous line during MUF, this is the venous line, and during MUF, the ultrafilter will pull from the venous line, pump it into the hemoconcentrator, and you'll notice this stopcock is turned so the blood flow will go into the oxygenator and not back to the reservoir. So let's look at the video. This is MUF on a 6 kilogram bidirectional Glenn patient. The numbers I would like to reference are the systolic pressure, common atrial pressure, and the hematocrit. Those important values will also be shown on the left side of the screen here, since they may be difficult to see in the video. And please disregard the yellow central venous pressure number. That was not working during this case. And you will see that we'll go through the 3 phases of MUF here. The normal volemic phase, where the perfusionist essentially keeps the filling pressures the same using the reservoir volume to replace ultrafiltrate volume. The hypovolemic phase, where hemoconcentration continues without volume replacement, where the patient will be brought down to a lower but safe blood pressure. And then the transfusion phase, when the venous cannula is taken out, placed under saline, and the residual MUF circuit volume is flushed forward. Here is the video. This patient started with a hematocrit of 37, a systolic blood pressure in the 60s, and a filling pressure of 2. The normal volemic phase of MUF starts, and the filling pressures actually rise along with the blood pressure as the inotropes are being adjusted. The hematocrit rises to 41. The process continues with reservoir volume being added to the MUF circuit. The perfusionist elects to increase the rate of volume removal and adds suction to the canister. All values remain stable as MUF continues, and the hematocrit rises to 44 to 45%. The filling pressure returns to a baseline of 2, and the perfusionist adds
crystalloid volume to the reservoir to help flush blood through the reservoir filter. The hematocrit rises to greater than 45 and MUF continues. The surgeon elects to go into the hypovolemic phase where volume is taken off but not returned. The systolic and filling pressures fall to a low of the 60s systolic and a filling pressure of 1. The venous cannula is pulled, placed under saline, and the transfusion phase is started. The venous line volume and MUF circuit volume are flushed forward to return as much circuit volume to the patient as possible. At the end of this case, the systolic pressure was in the 70s with a filling pressure of 2 and a hematocrit of 48.
And that is an overview of active ultrafiltration before, during, and after bypass, and how the hemoconcentrator can be a hero for you and your patient during cardiac surgery when used to its fullest potential. I thank you for your time and once again for this invitation. Good day.